guys, in this part, we'll start with variants of Meniere's disease. So, it includes cochlear hydrops, vestibular hydrops, drop attacks, or Lermois syndrome. First, we'll look at cochlear hydrops. Cochlear symptoms occurs only without the vertigo, which is a vestibular symptom. So, in cochlear hydrops, there are only cochlear symptoms. So, it is believed that the block is at the level of ductus reunions. Therefore, the endolymphatic pressure is increased, which is confined to the cochlea only. Therefore, the cochlear symptoms are only produced. Now we look at vestibular hydrops. Typical episodic vertigo with normal cochlear functions is a feature of vestibular hydrops. Drop attacks or Tumarkin crisis is also known as Tumarkin otolithic crisis. So there are sudden drop attacks without loss of consciousness. So a person walking normally will suddenly fall down. There's no loss of consciousness. The possible mechanism of this is due to deformation of the otolith membrane, which is macula of the utricle and saccule, due to the changes in the endolymphatic. So, if this is a rough diagram which includes the cochlea, the saccule, the utricle, and the semicircular canals, so here, due to the increase in the endolymph in the saccule and utricle, the pressure increases and increases. We know that the line that here there's a otolithic membrane which is known as the macula, which is responsible for linear acceleration. So when there is increase in the endolymphatic pressure here, there's deformation of this otolithic membrane, which is the macula, which is responsible for linear acceleration. Therefore, if the macula is deformed, there's loss of linear acceleration. Therefore, the person suddenly falls down without loss of consciousness. Lermois syndrome. So, Lermois syndrome is also known as reverse Meniere's. In this, there's progressive deterioration of hearing followed by an attack of vertigo. In Meniere's, normally there's initially an attack of vertigo followed by hearing loss and tinnitus and oral fullness. But in Lermois syndrome, there's hearing loss followed by an attack of vertigo. So it is also known as reverse Meniere's. Now we'll look at the diagnosis of Meniere's. So Meniere's may be diagnosed as certain, definite, probable, or possible. So certain only after histopathology we can confirm that it is a definite or certain case of Meniere's. Definite. Two or more definitive spontaneous episodes of vertigo lasting for 20 minutes or longer, along with audiometrically documented hearing loss on at least one occasion. So there should be two or more definitive occasions of vertigo. Out of those two occasions, at least on one occasion, the hearing loss must be audiometrically documented, and tinnitus and oral fullness must be present in the affected ear. All other causes must be excluded. So this criteria is necessary for defining the disease as definite kind of vertigo, definite kind of Meniere's. Probable. So at least one definitive spontaneous episodes of vertigo. Indefinite there's two, but in probable only one definitive spontaneous episode of vertigo must be present. All other conditions are similar, such as audiometrically documented hearing loss on at least one occasion, tinnitus or oral fullness in the affected ear or the treated ear, and other causes should be excluded. It is similar to that of definite, but at least one episode must be present in case of probable. In possible, there should be episodic vertigo of Meniere's type without documented hearing loss. So, if there are periods of vertigo but there is no audiometrically documented hearing loss during an acute attack, it comes under possible. Sensorineural hearing loss must be present, which is fluctuating or fixed with disequilibrium without definitive episodes of vertigo. So, this is cochlear variant, and if there are episodes of vertigo, it is vestibular variant. If the sensorineural hearing loss without vertigo, then it is cochlear variant, and all other causes must be excluded. So, this is possible. So, most of the cases diagnosed is the possible only. Now we'll look at the staging of vertigo. So first we'll conduct a pure tone audiometry, average of pure tone thresholds at 0.5, 2 and 3 kilohertz of the worst audiogram during a period of 6 months before treatment. So before treatment, so 6 months before treatment, we'll look at all these pure tone thresholds of the worst audiogram. So first we'll look at the staging. So stage 1 is less than or equal to 25, stage 2 is 26 to 40, stage 3 is 41 to 70, and stage 4 is more than 70. So all these are pure tone averages. Now we'll look at the treatment of Meniere's disease. So first we'll see about the general measures of treatment. So first we should reassure the patient. So this will relieve the anxiety of patient. And then we should stop certain things. So what are those things need to be stopped? First is smoking. So nicotine causes vasospasm, which we saw as one of the etiology of Meniere's disease. So smoking must be stopped immediately. The salt of the salt must be restricted in the diet, which should not exceed more than 1.5 to 2 gram per day. Water must be restricted. Overindulgence in coffee, tea, or alcohol must be avoided. Stress must be avoided. Should bring a change in the lifestyle. And activities requiring good body balance must be avoided, such as flying or underwater diving, because in case of vertigo, these professions will be compromised. So, in general measures, we should stop smoking, low salt, avoid excessive water, low coffee, tea, and alcohol, and avoiding stress. Now we'll see about the treatment of acute attack, management of an acute attack. So in acute attack, we should first reassure the patient to relieve the anxiety, and then bed rest. So the patient must be given bed rest with head support and pillows to prevent excessive movements, as the movements can trigger an episode of vertigo. And then IV fluids and electrolytes must be given to combat vomiting which may have occurred along with the vertigo. Vestibular sedatives must be given to relieve vertigo, which is given in case of acute attack. It is given either intramuscularly or intravenously. So in this, either dimenhydrinate or promethazine or prochlorperazine can be given. Or diazepam must be given 50 to 100 milligram IV. Tranquilizing, it has a tranquilizing effect and suppresses the activity of medial vestibular nucleus. So when you see this, then in acute attack, everything is given either IM or IV, since we have to relieve the symptoms immediately. And then atropine is can also be given 0.4 milligrams subcutaneously. Vasodilators such as carbogen, which is 5% carbon dioxide and 95% oxygen, can be given. It provides good cerebral vasodilation and therefore improves the labyrinthine circulation. So the mainstay of this is vestibular sedatives and vasodilators, which is to be remembered. In chronic for managing the chronic phase, we in this also we give vestibular sedatives, but in this they are given orally. The most commonly used will be prochlorperazine, which is given 10 milligram three times in a day orally for the first 2 months, and then 5 milligram 3 times a day for another month. So it is given for 3 months, first 2 months 10 milligram, and next month 5 milligram. And then vasodilators, in this beta histine is given 24 milligram orally. It releases histamine and increases the labyrinthine blood flow. It is contraindicated in asthmatics as it can cause bronchospasm. Diuretics, furosemide or thiazide diuretics or acetazolamide can be given. Furosemide 40 milligram or on alternate days with potassium supplementation is given. Propanthenol bromide, it is not generally preferred due to more side effects. Elimination of allergen must be done by desensitization or elimination of the particular allergen. Hormones, hypothyroidism should be controlled by replacement therapy to control Meniere's disease. Intratympanic gentamicin therapy. So, gentamicin, as we know, is a vestibulotoxic drug. Initially, streptomycin was given, but now gentamicin is preferred as it is less toxic to the hearing. So, gentamicin is vestibulotoxic. So it elevates vertigo without affecting or with minimal affecting of the hearing. So it is given as daily or bi-weekly injections into the middle ear. This drug will be absorbed through the round window, and then it destroys the vestibular labyrinth. The side effects of this will be hearing loss, therefore it is not given in initial stages. Then microvic also has a similar phenomena, except that the microvic is made with polyvinyl acetate, measures 1 into 9 millimeter. It delivers drugs from the external canal into the middle ear by tympanostomy tube or grommet tube, so that wick is passed through it. So in this tympanostomy tube or the tympanic membrane, a grommet tube will be inserted into tympanic membrane through which this wick is inserted, and the phenomenon of absorption will be seen, that the drug will be absorbed through the round window and destroy the vestibular labyrinth. Next is surgical treatment. So it includes conservative and destructive procedures. First, we'll look at conservative procedures which are most commonly used. First is decompression of the sac. Now, first, we need to know where the endolymphatic sac is located for appropriate decompression of the sac. So, the endolymphatic duct is located below the Donaldson's line. First, we'll see where is Donaldson's line and what is Donaldson's line. Donaldson's line is a line which passes through the lateral semicircular canal and bisects the posterior semicircular canal. This is a picture in which this is the superior semicircular canal, this is the posterior semicircular canal, this is the lateral semicircular canal. So, a line passing through the lateral semicircular canal and dissecting the posterior or bisecting the posterior semicircular canal is the Donaldson's line. So this line represents the location of the endolymphatic sac. The endolymphatic sac will be present just below this line. And then we can do endolymphatic shunt operation in which a tube will be passed connecting the endolymphatic sac with the subarachnoid space such that the endolymph will be drained into the subarachnoid space, the excess of endolymph. And then we can do sacculotomy, which is also known as fixed operation. In this, the puncturing of the saccule will be done with a needle through the stapes foot plate. As we know that the saccule will be distended and will compress on the stapes foot plate, therefore a needle can be passed through the stapes foot plate and puncturing of the saccule can be done. Cody's tack procedure. A stainless steel tack through the stapes foot plate is passed, so it causes periodic decompression of the saccule when distended. So in sacculotomy, we have to do it again and again. So Cody's tack procedure will itself cause periodic decompression when it gets distended. So the again and again it is not required to be punctured. Selective vestibular neurectomy. In this, the cochlear nerve is preserved, but the vestibular nerve alone. So we know that the eighth nerve is divided into cochlear and vestibular nerve. So after preserving the cochlear nerve, only the vestibular nerve will be sectioned or it will be cut off. So this will control vertigo but preserve hearing. Ultrasonic destruction of vestibular labyrinth. So again we are destroying the vestibular labyrinth but cochlear function will be preserved. In destructive procedures, whole of the membranous labyrinth will be destroyed including the cochlear and the vestibular labyrinth. So it is generally not indicated. It is indicated only in cases where the hearing loss is very prominent or there is already pre-existence of hearing loss or the ear is dead. Then they not preferred destructive procedures. The labyrinthectomy. Labyrinthectomy is also one of the destructive procedures. The last mode of management is intermittent low pressure pulse therapy, also known as Meniere device therapy. It is FDA approved right now, but the actual mechanism of it is not known. Intermittent positive pressure will be delivered through the Meniere's device into the external auditory canal. So this also requires the presence of a grommet tube or a tympanostomy tube in the middle ear. So first we will create intermittent positive pressure through the external auditory canal, and this positive pressure passes through the ventilation tubes and passes through the perilymph. Then passes through the perilymph. So this after passing through the perilymph, it causes reduction in the endolymph pressure by redistributing this endolymph through various communicable channels. So if we see the pressure passes, and then the endolymph will be redistributed into other channels. It can be self-administered, therefore it is used. But generally nowadays the medical therapy or conservative surgical procedures are only used. Thank you.